We are presenting a case from the cardiac core lab in Mons. It's a 68 years old lady that was presented with atypical angina with a coronary CT that showed lesions in the RCA and the LAD, and the angiogram, as you can see, there is a Medina 111 lesion that we're going to treat.
An EBU 3.5 with side holes, and before the first shot, we have put a wire in the LED so nothing can happen, dissection or other things. So we will now make the first fill. We agree that this is a Medina 111 with a kind of large diagonal branch as big as the distal LED. We have a BMW in place, and we will advance a second wire in the diagonal branch. In one stent technique, we agree that it is rather recommended not to do the pre-dilatation in the diagonal branch. But in this case, we will have to do the pre-dilatation in both branch. Then we have to do an OCT because of the nano crush study. Any recommendation on the OCT in this case?
So for this case, we are going to do an OCT for the side branch, an OCT for the main branch, then before stenting, another OCT, and then the final one. So for the recommendation, we have just to be exclusively in the left main, flush all the blood, and get a great image.
Are you concerned by the amount of contrast to do an OCT in both branch before and after stenting?
Around 16 ml per pullback for every artery. If we do the co-registration, where we can only use the images for the co-registration to evaluate angiographically and at the same time get the images from the OCT.
We will do the pre-dilatation with the Artimes&Wedge in the diagonal first and in the LED after. So you see that the balloon is advancing. I don't want to put too much of stent in the diagonal branch. What we can do now is a short stent boost. This stent boost, we will appreciate the calcium, and we see that it's finally, as always, much more than what you think. So I think that the pre-dilatation with a scoring balloon in the LED will be probably better. Take a wedge 2.5, 15 also. Then for the LED pre-dilatation, so the wedge is one wire along the balloon that will have a scoring effect that is important in order to prepare the lesion and also to avoid any slippering of the balloon. We recently conducted made the wedge trial with the version that is semi-compliant of this scoring balloon, and we saw finally that the use of the material was less in the group with the wedge than without the wedge, so that we were preparing more quickly the lesion. We were also avoiding slippery effects. So I think that it is, in this case, well advisable. And once we have pre-dilated both branch, we will do the OCT. See the wire that is outside, and when we do the pre-dilatation, it is then better to try to mobilize this balloon, advancing, retrieving, with the cutting effect of the extra wire being then at several locations. So very good profile, it crossed without problem. We will do a first inflation at this level. And you see immediately that there is then no slippering. The balloon stays in place with a small indentation on the balloon. And this is the non-compliant version. So if I want to improve the result, I can go all the way up to 24 atmosphere. Should we take the wedge in the side branch, 2.5? With the wedge, we will do a short inflation here to improve somewhat the results. This is opening nicer. So we will try not to go too far because I don't want to put a very long stent in this diagonal branch. That's better, huh? Perfect. We have a very clear image, so I will take the OCT wire out, not to leave this in position. Okay, we stop right in the left main. So we have seen enough of the proximal LED. So we take a stent that is 13 to 14 millimeter. Let's take the Artimes to the LED, and the stent, we will take a 2.5 14. This is the Angelite 2.5 14. This is an interesting stent also for bifurcation. The 2.5 can grow up to 4 millimeter. We agree. I advance the Angelite. We are now pulling back the balloon in the LED to be in front. And what will be recommended in this nano crush is to be slightly protruding, but really a minima in the LED. I am pulling the balloon of the stent, 2.75, 18. Donc, ici, on passe comme une fleur. 3.5, 6 millimeter pot balloon. We crush nicely proximally, and then we re-enter. We do a kissing. Very nice balloon with the shortest shoulder that we know. For the pot, this is optimal. 16 for the more proximal part. And so with this nano crush, we avoid the first kissing if we can go with the balloon back in the stand that has been nano crush. So this is the report. 14.
We are now live on the distal edge. We have no stent edge dissection. The stent is well opposed on the distal diagonal, coming back to the level of the bifurcation. We had the carina and not that much struts protruding, and we see the wire going to the LED in the middle of the image. And now we are back in the proximal LED. We have minimal malapposition on the upper side of the image, but for the rest of the stent, it looks well opposed.
So the question is this proximal LED lesion.
The criteria as we have is just that at the level of the lesion we have the 3.8 millimeter square with a fibrotic plaque, no erosion of the plaque with a plaque burden more than 180 degrees. And distally to this lesion we have an MLA of 9.5 millimeter square. Stent of 4 and the length around 10 millimeters.
I don't have to cover the ostium of the LED.
Agree that we don't need to cover.
Just the 4-0, leaving a stenosis of 4 or less millimeter square before or after a stent is calling for thrombosis. This is a very old work published by Kenichi Fuji when we were in New York, and it remains very important. So I think we fixed this proximal LED opposed, and we didn't see any problem at the margin. I think that we have the proximal LED that was made, and it was important, and now we are good.